Meeting for Monday, March 2nd, 2020. Will please come to order, and the clerk will call the roll.
Calling the roll, Mr. Miller.
Here.
Mr. Tuma.
Here.
Ms. Simon. Ms. Simon is absent at the moment. Mr. Gallagher. Here. Mr. Schron. Mr. Schron is absent at the moment. Ms. Brown. Here. Ms. Baker. Here. We have a quorum. Also like the record to reflect that Council President Brady is also in attendance.
Thank you, Council President, for joining us. And the next item on the agenda is public comment. Do we have anybody signed in for public comment?
No, Mr. Chair, no one is signed in.
Thank you very much. And next we have the approval of the minutes from the February 19th, 2020 meeting. Those minutes are in your packet. Do we have a motion relative to those minutes? It's been moved and seconded to approve the minutes from February 19th. Any further discussion? Hearing none, all those in favor say aye. Aye. Any opposed say nay. And the ayes have it. The minutes are approved from February 19th. And we have one item that has been referred to committee, Resolution 2020-0046 for second hearing.
Resolution number 2020-0046, amending the 2020-2021 biennial operating budget for 2020 by providing for additional fiscal appropriations from the Opioid Mitigation Fund to meet the budgetary needs of various county departments, offices, and agencies.
Okay, thank you very much. And I understand that there is a substitute of technical changes, and the first thing that we'd like to do this afternoon is have someone from the administration explain to us exactly what the substitute does and why it is needed.
Good afternoon, Council. Randy Carney, Chief of Special Operations for the county. Thank you for having us in front of you today. The substitute language that was proposed, as you said, it was a technical matter. The language previously had identified approximately $10 million to go to the Adams Board, and the language stated $10 million for increased in beds. What that $10 million is actually for is it's $10 million that goes to Adams, and Adams is subbing that out to three different projects. One is Stella Maris, for Stella Maris to increase their bed capabilities. Another is for the Thrive ED program, and the final is for St. Vincent Rosary Hall program. So it identifies the three projects under Adams that they would be subbing the money and contracting the money with.
Okay, does anybody have any questions about the substitute? Okay, we're going to take the substitute under advisement. We're going to have our staff take a look at it, and hopefully before the end of the meeting we'll be able to move forward on the substitute.
Thank you, Councilman.
So now we would like to, I would like to note that Councilman Schron has joined the meeting, and we would like to move forward to the general discussion on the legislation. Please update us on the additional information that you've been able to bring forward for us.
Sure. Thank you, Councilman. Today I'm in front of you requesting appropriations for the projects that were approved by County Administration and Council late last year for use with opioid settlement funds. These initial projects will cover up to a 2-year cycle and total approximately $23 million. The dollars will immediately support the needs of the opioid epidemic, which we all are so unfortunately aware of, to cover immediate needs such as expansion of beds at Stella Maris, costs to support the increase of children in custody through Children and Family Services, costs for additional staff and equipment with our medical examiner, and for education and early education programming throughout the county, to name just a few. I also want to note that I have representation from a number of agencies that would be receiving this funding in the audience if you have specific questions for them. That includes Department of Children and Family Services, the Adams Board, the medical examiner, And the Common Pleas Court had mentioned that they would have someone, I'm not sure if they've made it yet, if there's any specific questions for them.
Okay. I think that we should have each of the representatives come forward and provide additional detail about their particular funding requests and explain what the metrics are going to be for their programs.
Excellent. If I could propose having Adams first, since they are one of the larger bulks of money in front of you.
That would make sense.
Thank you, sir.
Thanks, Brandy. Put the PowerPoint up, all right? Good afternoon, Council. I'm Scott Osicki. I'm the Chief Executive Officer of the Adams Board of Cuyahoga County, and I prepared this folder for you and a PowerPoint presentation, so just want to walk you through that if I can. So the first thing that we have here is that first of all, thank you for allowing me the opportunity to be here. Our board of directors wanted to make it clear and make sure that Cuyahoga Council receives the facts about the investment and the involvement of the Adams Board in the Phase 1 Opioid Mitigation Settlement Plan. So our board, they passed Resolution 200207, Adams Board Efforts Regarding First Round Opiate Settlement on February 26, and there is a copy of the resolution in your packet. Our board also,
Before you continue, we have a lot of paperwork up here. Did you pass out an item that looks just like
folder.
that item? Okay. Oh, okay.
Okay.
Great.
Yep. So there's a copy of
Okay.
the, go ahead, yes. And then our board is asking that this resolution be part of the record of today's meeting to acknowledge some clarifications that were made in the last meeting. So if my board would like to have that, and the copy of the resolution is there for you. And then just some highlights of that resolution. So one is that the Adams Board CEO, me, and staff involvement in the opiate litigation that resulted in settlements. That the Adams Board CEO, staff, and providers quickly responded to requests from the Cuyahoga County Executive's Office on developing a plan and services for the best use of that first phase, which resulted in the Adams Board being allocated just over $10.5 million. Since October 2019, we've continuously and diligently worked with and responded to staff requests from the Cuyahoga County's Executive Office about releasing these dollars to us, including providing program descriptions and metrics. An email was sent to County Council by me on February 19th, which included some proper information regarding the programs to be funded by the Adams Board and the metrics and timelines that were submitted. And then also, the resolution formally requests that the Adams Board be included in the planning and discussions related to Phase 2 opiate settlement. So what I have here is a slide that represents the programs that we will be funding with the 10.5. The first is Stella Maris, and I also want to introduce to you Daniel Lettenberger Klein. He is the executive director of Stella Maris. St. Vincent and Rosary Hall, Dr. Biscaro, he couldn't be here with us today. He had another appointment. And then Thrive Peer Support, we have Brian Bailey's, who's the founding person and CEO of Thrive. So the first of going through the programs, you can see that with Stella Maris, what we are doing with these funds are 32 new residential treatment beds for 260 clients anticipated to be served in 1 year. An expansion of the partial hospitalization, intensive outpatient program, and the medical assistant treatment program for about 312 clients are anticipated to be served in that year. Their total allocation is $5,433,207. $4,159,582 will be used for the treatment beds, and about just over $1.2 million will be for the partial hosp, IOP, and the medication-assisted treatment. With St. Vincent Rosary Hall, it'll be the expansion of their partial hospitalization and intensive outpatient program, which anticipates serving 240 clients in the IOP program and 130 clients in the PHP program. They're also going to enhance their 24-hour intake assessment, and then they're also going to expand peer support, which would roughly serve around 2,000 clients at a time with the money. They are getting $2 million, and that's spread over 2 years. And just over $1.2 million would be for the PHP and the IOP program, $441,000 for the 24-hour intake, and $330,000 for the expanded peer support. Then Thrive Peer Support, so that is the Thrive ED Peer Recovery Coach Enhancement to 10 university hospitals and Cleveland Clinic emergency rooms. They are anticipating serving 500 clients with this funding, and then also creating 100 peer recovery coach jobs are anticipated, and that's for just over $3 million. So then what I did next is I took each one of the programs. Now, I emailed you that day the longer list of the timelines and the metrics, but these are just the highlights from it. So with the Stella Maris for the 32 residential beds, 16 for men and 16 for women, during the month of March here, we are anticipating approving the contract on March 25th with our Adams Board pending release of the funding of the $4.1 million for this program. Our contract date would be March 1st through July 31st, 2021. $681,000 would be provided as a startup for renovation of a convent near the property of Stella Maris for temporary 16 women's residential treatment beds and the program staffing. $982,000 will be a startup cost to purchase and renovate the Atwood building to serve as a permanent space for the residential treatment for both the men and the women. About $2.5 million for the staffing, services, room and board to be provided on a 1/12 basis because we are paying for capacity. They have to have the staff there in order to provide the services when they come in, when the folks would come in. Stella Maris in March was hopefully to be signed the lease by for the convent. Stella Maris to begin increasing staff to operate the residential treatment with full staff by the end of June. The staff include nurses, counselors, residential manager, case managers, and a psychiatrist. In April of 20, Stella Maris to submit monthly reports with the identified metrics that we have. Stella Maris to submit the receipts for all their startup costs as they're using them, so our accounting department could reconcile all of that. And then Adams Board, that's what it says, to reconcile the startup receipts. So the measurements there are data will be collected daily and reported to the Adams Board on a monthly basis. So Adams Board staff will also conduct face-to-face site program reviews every 3 months or as needed as we're monitoring the programs. The monthly report will include the number of men and women admitted to residential treatment, their referral source, the number of denials into the program, including any reasons for that. Information on the client would be their diagnosis, their race, their age, their zip code, their housing status, employment or school status, if they're involved in the criminal justice system. We'll also collect information on the length of stay, so number of people who completed the program and the number of discharges and terminations and the reasons, whether they were discharged for completing the program or discharged for any other reasons. And included in that would be the length of stay, how long they were there. Also, the disposition at discharge would be where is the client going from them? Are they being referred to sober housing? Are they being referred to other programs? The average cost per the client, we're going to be figuring that out along with Stella Maris's help. And then the average caseload per staff to see how many folks that they are each serving. Some highlights on the timeline. So May 2020, that Stella Maris to have final renovations of the convent completed and treatment to be provided in this location until moved to the permanent location. So in June of 20, the Adams Board staff, that's when we would have our first face-to-face because there would actually be some things to see there. And then Stella Maris will have their certificate of occupancy for the convent. In July of 20, Stella Maris will officially start providing the residential treatment program for men and women in the temporary location. The program will be provided in either Stella Maris's supporting housing unit they have now or the current detox space contingent upon completion of the Atwood building. Residential treatment for women will be temporarily provided in the convent. Stella Maris would submit to us the receipts for the 1/12 allocation for the residential treatment services provided. And in July of 2000, we skip forward to July of 21. That's when Stella Maris's anticipated residential treatment program for men and women operated at the Atwood building. Stella Maris will conduct an annual review of the program, and Adams Board and Stella Maris will conduct a final review of the program to determine sustainability and ongoing funding. The next one is for Stella Maris also, the expansion of the partial hosp, intensive outpatient treatment, and the medically assisted treatment program. So March 2020 would be, once again, us passing the resolution and passing the contract and signing that with Stella. And that, for increasing staff as well for those, for the PHP and the IOP. In April, the Stella Maris to officially start their expanded PHP and IOP and MAT in their existing space that they have on campus. They have room to add additional sessions, and it would be at different times during the day, so they're adding more, but they already have that space. They will submit their monthly invoices and also with the identified metrics that we have for this program as well. And once again, we'd start the review in June, and in April, they would actually conduct an annual review of their program, and Adams Board and Stella would come together to also look at sustainability and ongoing of these expanded programs. So the data collected will be very similar to the other program, number of men or women participating in each one of those programs. In addition to the referral source, if anybody was denied and the reason why, the same demographics that we had from the other ones, length of participation in the program, so did they actually complete the program in the days required or not, and then the disposition of what happened after they completed that program, and then the average costs. So also in the timeline here is looks like I copied that twice, I think. Nope, that was it for Stella, I'm sorry about that. So St. Vincent Rosary Hall, so the same thing, the timelines developed and the measurements. So Adams Board, the contract for hopefully on March 25th for about 1.2 million, and we know this one is going to extend for 2 years. St. Vincent is going to identify their steps for expansion targets, and adequately staffing of their partial hosp and their IOP programs. In April, they're going to start submitting invoices us for the cost reimbursement of services provided, including the metrics. And St. Vincent will submit monthly reports to us containing the metrics. In May, St. Vincent is going to begin its PHP and IOP expansion sessions. In June, the Adams Board staff will begin our face-to-faces. In August is anticipated full expansion of the additional IOP and PHP teams at St. Vincent. In August, that was the full expansion, sorry, they're going to conduct their annual review of the programs, and then also they are planning on having a strategic partner for sustainability, and they don't know who that is yet, but they're looking into that for adding more sustainability to the program beyond these funds. So the data that we will collect on this will be very similar to the other ones as well. The monthly report, referral source, the demographics, length of stay, disposition, average cost. Also some highlights in March of, this is for the enhanced 24-hour intake now. So once again, the contracting. Then St. Vincent is going to begin their initial phase of the intake redesign. So they have to hire leadership for this program, cross-training of the staff that are there, and then staff to expand the hours to 24/7. They'll also begin submitting the invoices in April. In May, that's when they will initiate the advanced phase of expanding that assessment and intake to allow for 24/7. On their measurement side, then these are a little bit different, because what they will do is they will report to us the number of assessments started and completed, the time of day the assessment was started and completed, the length of time that each assessment took, the level of care placement for each client as the result of their assessment, the referral source to intake who referred them to the program, and then the number of denials and admissions, including the reason why, the same demographics we had for the other ones, and then the average cost per client and average caseload per staff. In August of 20, that's when they anticipate having full expansion of their 24/7 capability. In December, they're going to conduct a review of their programs and the impact that it's having. By January, they anticipate it operating at full capacity. In July of 21, they will have at least 1 or 2 key strategic partners for sustainable access. Then they're also going to conduct their annual review and the annual review with us in January or February of 22. Their expansion of peer support. So once again, kind of the same timeline that we're looking at there, the same same measurements that we're having there, except there's a little bit different there with their monthly reports to us, is the number of peer supporters that they have, the recovery coaches, how many of them are there employed, then as well as the number of people that they see, and the different questions of location of the peer interaction with the client, where did it happen, in an emergency room, in other facility, the direction of the peer visit with the client, duration of that. Has the client received treatment previously and identified as a person with addiction and mental illness, or both? The types of services that the client was interested in receiving. Was the client transported, to where and why? And then the average caseload per recovery supporter and coach. Then in December of 21, St. Vincent, once again, will be conducting their annual reviews. And then the Adams Board and St. Vincent will also do an annual review to determine sustainability and ongoing funding for this. So then we come to our Thrive peer support. Once again, the same kind of a contract timeline there. They will receive $417,000 for startup, for vetting, hiring, and training their peer recovery coaches. And Thrive to begin the recruitment of estimated 80 peer recovery coaches at this time, but we're hoping that it'll be 100. Then they will begin in April submitting their monthly reports to us, submitting receipts for all the startup costs, submitting monthly invoices for services that are provided. And then in June, the Adams Board staff face-to-face again, and in February of 21, getting together with Thrive for the final review of this part of the program. They will also be conducting this, collecting the same measurements as the St. Vincent peer recovery program. So the measurements of what we picked and why. So the measures we've chosen are important to illustrate the quantity, quality, and the effect of the programs and the services provided. We want to ensure that services are provided and funded as per the contract. We want to measure success and make revisions as needed in the program to ensure the best outcomes for the client. We want to provide data to illustrate program efficacy and make decisions on future continuation of funding. And we also want to illustrate the benefits of the program to potential clients as well as the entire community. So if the measurements go up or down, they could mean a variety of things: that the program is successful or it's not, that changes to be made to staffing and or treatment modalities, marketing of the program may need to be increased to increase referrals, the program funding may be adequate or it might not be adequate, and that the program may no longer be needed based on the trends of the individuals served. So that was just kind of in a quick summary of all the work that we put into this with our providers and also with coming up with the metrics and the timelines.
Thank you very much for that presentation. In the meantime, Ms. Simon has joined the meeting, and she has indicated the first request to ask questions.
Thank you so much, Mr. Chair, and thanks for the presentation. I just have a quick question about the location, and maybe I missed it, of the Atwood,
Okay.
Stella Maris's Atwood building. Where is
Yes.
that?
May I have Daniel approach and answer the question for us?
the
Daniel,
chair, yeah.
Mr. Chair, may I have Daniel? He is the CEO of Stella Maris. The Atwood building.
Hi, we're attempting to purchase property. Here's the microphone. We're attempting to purchase
Could
property.
you
that's
state your name for the record?
Daniel Lettenberger Klein, Executive Director with Stella Maris.
Thank you.
We're attempting to purchase property that's adjacent to ours, so it's on the same block. So it'd still be walkable. It's right next door.
It's next door. And what's so you're attempting to purchase?
Yeah,
Does that seem likely, or?
yes, we've already spoken with ownership, and there's a potential for acquisition. They're interested in selling. It's just about relocating their existing business.
Okay.
Just wonder where the convent is too.
Oh, the convent is at St. Malachi's on
Yeah.
the corner. They approached us as well as soon as the convent was empty, so that's walkable. Transportation is a significant barrier for people in recovery and early recovery, so we tried to strategically plan for locations that were close by that were walkable and safe.
Okay. The convent, same. Okay, that was the next question. Okay, thanks.
Okay. We have Councilman Tuma, followed by Brown.
Thank you. Through the chair. Mr. Osicki, as far as the individuals who enter these programs through these facilities, are these voluntary or are they court ordered, or how does that work out?
They will be voluntary, but they could be court ordered as well, depending on their individual situation. But a lot of it is self-referral for treatment.
Okay. And then I understand through your metrics there are a variety of factors that go into that, but is one of your primary factors going to be recidivism? You know, people coming back or seeking
Yes. Yes, that's why when we're keeping track of the folks who they're serving, we'll be able to see if they come back into the system and how many times. And recidivism it's a part of recovery. A person may have to go through it a couple times, but that way we will be able to see how many times people are coming back through the system, as well if changes need to be made.
So are there folks? I guess what I'm asking, from these types of addictions, these opioid types of addictions, can individuals who enter these facilities, can they go on and lead, good lives without having to come back after certain amounts of treatment, or is this something that
Oh, no, there are many people living in recovery, and that's why we are advocating for the peer support, because when the peer with lived experience of going through the addiction and living in recovery, how that's an important part of keeping people in recovery.
Right.
And the peer recovery coaches are examples, of people living in recovery, and we have a lot of success stories.
Okay, wonderful. All right, thank you.
Okay, next we have Councilwoman Brown, followed by Shran.
Thank you, Mr. Chair. Very thorough presentation. Thank you for putting it together. I have a couple of questions. One is a point of clarification relative to the $10 million. And I just almost made what I think might have been the same mistake you made with the client's anticipated serve. You stated 500, but our slide shows 5,000. So I just want to make sure that the number that's before us is correct.
I'm sorry, it is 5,000 for the peer support, yes.
And then relative to the Thrive Peer Support ED program, just curious as to the selection process for University Heights and Cleveland Clinic versus St. Vincent and Metro Health.
University hospitals.
Oh, University Hospitals.
Mr. Chair, can I bring up Brian Bayless to answer this question? All right. Thank you, sir.
Thank you, Councilman.
Please introduce yourself for the record.
Brian Bayless, CEO of Thrive Peer Support.
Thank you very much.
So we are currently doing work in St. Vincent and in Metro Hospital.
Okay.
We staff Metro's 24/7, 365, and we staff St. Vincent 16 hours a day.
So the programs are already existing.
They already
so
exist.
They don't exist at University Hospitals nor Cleveland Clinic.
That's correct.
Okay. Thank you very much. As it relates to the Stella Maris new 32 residential treatment beds expansion, will there be new staff or already staff on board to address the expansion?
I believe they will be new staff. That's because they are ramping up and adding additional beds. And if I can ask Daniel, is that correct? Yes. Mr. Chair? Yes, new staff.
Okay, and if you could just let us know what that count looks like as far as the new staff. I know you probably don't have that before you. Additionally, you mentioned the data that's going to be captured with reference to those who have been declined or denied services into the program. Will that data also be captured for them as well?
Yes.
Okay, and I think that completes my question. Thank you very much, Mr. Osei.
Thank you. Councilwoman Brown?
Councilman Schran.
Thank you, Mr. Chair. We've identified 3 programs in regards to what you presented here today.
3 different agencies.
3 different agencies are going to be
delivering.
delivering.
There's different programs.
Yeah.
Yes.
How many different agencies are there in Northeastern Ohio that would be able to service this kind of population?
The Adams Board provides service contracts with about 60 providers, mental health and AOD, but only certain providers can provide the residential treatment because they're certified for them or have the space. Stella Maris is expanding. Catholic Charities is one that does residential treatment. If I may call upon Maggie, our Assistant Chief Clinical Officer, she has the better stats on that.
Good afternoon. Maggie Tolbert, Assistant Chief Clinical Officer at the Adams Board. So we have a variety of other agency, Orca House. We have a Hispanic Umadoc that does residential. As Scott has stated, Catholic Charities. We also have agencies that provide some of the other programs, the detox also, that would be like Salvation Army, Harvey Light within the community, as well as St. Vincent also does Rosary Hall detox.
And some other providers might do the intensive outpatient treatment and the partial hospitalization as well.
So for the partial hospitalization programs, a number of our private hospitals also do that, but also our community mental health agencies that the Adams Board. You've heard of Signature Healthcare. They provide partial hos, was a program. Also intensive services is Recovery Resources also does those services.
So how many is that? Give me a rough idea. We have 3 here we've identified.
So
many
who's currently doing residential, there's like 5, and I can give you the specifics, names of the agencies and their location. I can send that to you. For the intensive outpatient, we probably have 6 to 7 agencies that's doing that. Partial hospitalization, we have the private hospitals like the Cleveland Clinic system. We don't fund them, but as the ones that we do fund for partial hos, I think there's like 4 agencies that's also providing that.
So I'm just trying to keep track with your numbers that were coming. Sounded like almost about 15 to 20. Is that?
As a total, maybe, yeah.
How many of them competed against these 3?
I could answer that.
Okay.
Right. None of them have competed for this. We responded to a request to pull together what we felt would be the best way to spend that first round of opiate dollars. We know that we needed additional residential treatment beds. That is how we picked Stella, as well as their fantastic reputation that they have in the community of serving individuals. They already do a great job offering the IOP and PHP, so it only made sense to go with them to expand that as well. St. Vincent Charity, they operate our 24-hour psych ER in Rosary Hall. They also have a great reputation as well, and they could also expand the IOP and the PHP, and they offer detox there. So those, and then Thrive is the only provider that we currently have that provides peer support.
So, but if I'm understanding your number, you said there was roughly 20, so 17 of them were not part of this process.
That is correct.
You selected it on your own.
That is correct, and that is it's part of the way of the Adams Board. That is our right to do that. We do not have to issue RFPs for services. And plus, also, this was a quick turnaround that we were requested from the county executive's office, and we made the best decisions that we feel are the best.
I guess I'm a little chagrined with what you have the right to do this.
Mm-hmm, we do.
And you're coming to this body asking for money.
Mr. Schwan, I'm not trying to be argumentative. I'm just telling you the process that we used and why we did not issue an RFP. It has nothing to do with coming and asking you for this. It is the part of how we went and selected the best providers that we did.
And what's your definition of success with these 3?
The success are based on the years of service that they have all been in. Thrive is a new organization, and we know they're expanding throughout the state, and they have great outcomes with the number of peer supporters that they have and the number of people that they help stay in recovery. Stella Maris is one of the first places that people turn to for detoxification services, and St. Vincent Charity stands on their own legacy of serving people for all these years.
And what I heard an awful lot was hiring practices and numbers and head count and things of that nature. Mm-hmm. What I didn't hear is you defined the best outcomes for the individual. Mm-hmm. Where are those metrics?
Those metrics are there, sir. That's
for the individual?
Yes, we're asking about what happens to them. We're asking about how long they've been in treatment. When it comes back through, when we're looking at the end, we'll know where those people are. That's the disposition, which is the most important part of the whole thing about coming up as who in recovery is what happens to them afterwards.
And this data is going to provide us with the program efficiency?
It should. That's the price per person. That's the number of clients per caseload that each employee has. So yes, it will. It'll provide efficiency. We'll have the numbers at the end of that.
Thank you.
Ms. Baker.
Thank you, and thank you for your
detailed overview. I appreciate it.
Thank you.
Good to see where you're going. A couple questions, because this is the first time I've seen this is right now. So I hope I'm not saying something I should already know. But how many beds do you have now that you're treating for those that are in need?
In residential treatment, we have, excuse me, Maggie, do you have the number of beds? Mr. Chair, if I could ask Maggie, if she
That'll
keeps track
tell me
of that.
what 32 beds means in
That's
addition.
Yes, it's a lot, 32 beds.
Maggie Tolbert. For residential beds, currently, we have a total of 354 now.
354.
Right. And so with the expansion of the 32, that will be 386.
Okay, so you have a substantial amount of beds now. So this is just enhancing what we're already doing. So the 354 beds that you have now, are they under the same program of making sure that those that are treated follow the same guideline that you have here?
Yes, because all the residential services have to follow the standards that the state set.
Okay, and what you have set, right? I mean,
It will also,
yeah.
Councilwoman Baker, it'll be increased to match the same statistics that we have here.
Okay.
The same measurements, yes, so they will all be treated the same way once we get going with this part.
That was my question.
But they are monitored by our staff. We have program staff, and they're in constant contact with with all of the providers, actually.
So this is about a little less than 10% increase of your existing beds?
Yes.
Okay, I didn't know that. Secondly, how do you segregate the dollars that are being used for opioid and other issues that they may be coming in with that these opioid dollars don't pay for? How do you,
Yes,
you know,
yes,
yeah,
yes.
I
That would
understand
be
the question.
account for the dollars that come in and how we spend that. I have our Chief Financial Officer here with me, Felicia Harrison. She has various accounts set up that she tracks. We get SAMHSA grants. She has accounts. I'll let her answer that. Yep.
Hi, Felicia Harrison, CFO for the Adams Board. Yes, we track everything basically through Famous, now moving to through the new ERP system. So we have separate funds set up for any grants that we have, for different projects that we have. We set everything up separately.
so if someone comes in and wants one of your 32 beds and they have multi-issues, mental health, or there's all kinds of different things that could be coming in, you would then categorize that person to say these many dollars go here and these many dollars go, and you know per person how much the opiate dollars impact that person beyond the other needs that he has? Do you go that detailed?
Yes, what we do is usually have the providers submit invoices or information as to what services the person needs. And if it will be covered by the opiate dollars, we will charge it to the opiate, used to be called index code, not sure what it's called now. If it's for other programs, we will charge it to those other program funding sources.
Okay, good. It's good to know. Also, is there any research or anything done with matching dollars or grants or federal? Is there anything that would enhance your 10.5 million right now that could perhaps give us a better bang for our buck?
We will be looking into, like, some of the services that will be provided. If the person is Medicaid eligible, we will look into charging that to Medicaid to help us to extend the dollars.
Is there any other way that you could be receiving grant? I mean, we see grants all the time on different things.
Right, we do have state opiate response or SOAR grant money that we're monitoring right now. It is fully allocated, but we can always look to see if we do receive additional SOAR dollars, can we use those dollars to supplement these programs?
Will that be part of your reporting to let us know that perhaps you've turned 10.5 into 12 or 15
We can
million in
certainly add that.
return? You have that part of your
We can add
reporting?
that. Okay, yes, ma'am.
Lastly, and I don't want to duplicate a question that was asked, but I'm not sure I heard the answer. The measure of success for the person that you're helping, how do you, with all your reporting and identifying different needs, how do you know that adding those 32 beds actually made a difference in someone's life, that they are able to go on to a productive
Councilwoman, what we will know is, we'll know the names of the people who come in, right, that are utilizing those beds, those additional beds.
Yeah.
We'll know what they move on to. If they move to intensive outpatient, if they move to partial hospitalization, if they move into a sober living environment, if they're participating in those, if those programs as well. We will know if they are relapsing back into the system because we will see their names. When we have our agencies submit to us their invoices and we know the people that are there, we check to see if they've been in the system before. So we would be able to know, if a person is coming back again. When we don't hear from them anymore, we are assuming that they are living in recovery and they're moving on to much better things. But relapse, unfortunately, is a part of the recovery process. So we probably will see some people coming back, but that gives us an additional chance to see what other things could we do. Maybe residential treatment, staying there longer than just 30 days, and maybe staying longer in those other programs as well. So we'll be able to track that for you to let you know how many people are coming back into the system again.
Right. I guess.
Or back into the same services, I'm sorry.
Yeah, I guess the ultimate goal would be to have someone that doesn't need your services anymore.
That is correct.
Right? And I just wondered if,
yes.
if you, if that is a goal that you would be wanting to share with us at the end of the day, saying that whatever percentage of people, not only with your 32 beds, but your 354 beds, had not just tracking to see whether or not they come back or need more services because it's one-time money, but you actually were able to be successful through your methods of helping them, that they will not be back.
Yes, and that is also like peer support that may go on for a very long time, because the person will continually need to have the peer support while they're in recovery, and then hopefully that they move on to help other folks as well. It's a whole part of the process. But yes.
Okay. And one last question, if you don't mind. The amount of beds that you're adding, given that it's about 10% more, do you think that is a significant, how much are we actually going to see a difference by adding those 32 beds? And if I may also ask, is that a number that you picked because it was the appropriate amount of beds needed, or would you like to see 50 or 100 beds more? Where are you in that number?
There is room for more that we could have. They're anticipating, Stella Maris is anticipating, 210 or whatever clients through those beds.
Right.
So those are 210 clients that we wouldn't be able to currently serve in our system now.
Right. And the Atwood building, I heard you say earlier, or someone say earlier, that they're trying to move a business out of that building. Are you confident that there aren't any? Because you have a move-in date of March, I believe.
If I may,
Yes.
Mr. Chair, can I call Daniel
Is there
back up
any
to
issue
answer
there that
question?
you think that your
Daniel?
current tenant may not move out? Or maybe slow in moving out?
Do I announce myself again? I'm Daniel Ettenberger, Klein, Stella Maris. We're fairly certain that this is something that can move forward, but with any negotiation, there's always room for error, and it is an existing business that is not looking at discontinuing, it's looking at moving, so there's unique challenges to that. So it's hard to answer whether there would be delays, but we're doing everything we can to engage the owner to make sure that it's a smooth transition. We want to limit any business disruption for any of our neighbors.
Mr. Oseki, do you have a plan B if this does not materialize?
Don't you have a plan B of using other available beds?
Yes.
Yes, so if you want to tell them that,
Okay.
otherwise, yes.
So our plan B and C is to offset the beds in our supportive housing dormitory that we have on campus. There's 46 existing supportive housing beds. The first floor of that would be the backup plan. There's 18 beds on the first floor that we would accommodate that for ADA accessibility so that we could make sure we could do treatment there. The backup plan is because we're in the middle of a capital campaign to expand our 3.7 detox services. July 1st is our tentative open date for those 20 beds in our detox center. We would use the pre-existing detox to house the residential beds in the event that we could not move forward with the Atwood building or if there were disruptions in that plan.
Okay, that's good to know. Thank you. Thank you, Chair.
Okay, thank you very much.
Okay, thank you, everyone.
I would call upon Ms. Carney to bring forward the next presenter.
Sure. Thank you, Councilman. If I can call up Dave Merriman, the Chief for Health and Human Services for the county, to speak of the Department of Children and Family Services funding, as well as the Family and Children First Council funding.
Thank you.
Good afternoon, David Merriman, Interim Director of Health and Human Services, and I'm joined by Robin Martin. In a minute, we'll have Tammy Chapman-Wagner join us as well. First, wanted to thank you for the opportunity to join this discussion. I know Robin has an external commitment, so I thought she should come forward first to explain the update as to where we stand with the use of these funds. We did not bring along a PowerPoint presentation. We could provide additional detail if requested. But let me go ahead and turn it over to Robin Martin, Director of Family and Children First Council.
Good afternoon, Robin Martin, Family and Children First Council. So currently we are, our portion is designed to address the school piece and doing prevention services within the schools. So we have reached out to multiple school districts in Cuyahoga County that we were made aware that had an existing program to find out who implemented their program, and our plan was to issue an RFP to those providers and have a provider pool and then offer services to all schools in Cuyahoga County and outsource that provider pool. During the process of our investigation, we found out that there were some state funds allocated to our local Adams Board and the Educational Service Center of Northeast Ohio that had a similar requirement. So we backed off of our initial plan, and we are now participating in the work group with the Adams Board and the ESC to make sure that we are not double dipping and to make sure that we're making the best use of these dollars. So my understanding is their scope is broader, and what we would ask is that we would participate on the opioid portion while they do a broader scope of services for the other kids. So we are still in the process of figuring out what that looks like. I think we've had 3 meetings, and hopefully we should have a plan by the end of this month. And then the second set of dollars, we were unaware, the 90,000, we were unaware that those dollars were available. So we are just beginning a process to get information about the program that is currently in place at, I think it's Bay Village City Schools, to figure out what they have been doing to identify local providers that can offer this service. Our understanding is the provider used in Bay Village is in Canada. And so we're trying to figure out if we have local providers, so we will issue an RFP for that funding as well.
So you have 2 items, one which totals 300,000 and the second one which totals 90,000 over 2 years. Is that
Yes.
correct? Okay. Questions? Councilman Tuma.
Thank you, through the chair. Yeah, obviously this is a very important component of all of this, is educating people. And have you guys, through your department, been in touch with the medical examiner's office as far as available programs through schooling, through education? Because a couple years back, I was able to get some funding for the Parma City School District, and they had a local provider in there. They did a very good job, and so I wasn't sure if you had any contact with them, because that's where I got the information from, was from the medical examiner's office. So again, without reinventing the wheel, if you will, that's one place you might want to look moving forward. So.
To the councilman, through the chair, we actually reached out to the school districts directly, because when we were given the information regarding the funding, there was a list of schools in the write-up. And so we started with that group of schools, but I was aware of the project with Parma, and so that vendor is also on our list. So we knew we didn't need to reach out to Parma, but we reached out to the other districts.
Okay, that's fine.
But
I
we
just wanted to
can
make sure
also
that,
check with the medical examiner's office.
You were talking about local, and I just want to make sure that you had access to something like that. So, okay, appreciate it.
That's great information.
Thank you.
Councilman Gallagher.
So there are existing programs in the schools, right?
Some districts, not
Okay.
all. So what we're finding is we're finding some districts are using the DARE program through their police departments. Some districts are using external providers, and then other districts are doing an in-house, and we're having a hard time getting clear information on the ones that are doing in-house, how they're doing it or what they're using, but we're still working on it.
Now, what we're dealing with here was an opioid explosion, basically through folks that aren't in grade school, junior high or high school. Why are we taking 300,000, maybe 90,000 more, and not putting it into beds, which we all know we need? Why are we putting that kind of money into grade schools, junior highs, and I don't know if it goes to high schools, when it doesn't exist, the problem isn't there, and this is money specifically for the folks that are affected by this crisis? What's the thought process? How did we get to taking that money and putting it into grade schools?
To the councilman through the chair, I'm sorry, I can't answer that. I was not a part of that decision.
Who do you think might have been?
David?
Again, David Merriman, Health and Human Services. First, I don't know that I can agree that there isn't a problem in the high schools and maybe below as it relates to opioid use. I do know that we are largely responding to the crisis as it exists in America and where the deaths are, but we know that caring for children is a top priority for this administration, and we do know that there is drug use within...
So the answer to my question is it came from the administration.
Brandy Carney, Chief of Special Operations for the county. I can't speak to how these initial dollars, this decision for the $23 million. What I can say is the priorities, both within the settlement language itself, as well as the county, the press event that was done, and the council administration document that was put together. The priorities included treatment, recovery, and prevention. So prevention, as we all know, is educational programming. So allowing this programming to get to the children in the schools before it gets in front of them, and them to have an understanding of the epidemic and what it can do. And so this is a component of that prevention programming.
Well, it seems to me to be pretty interesting that you could come up here and ask for money and nobody seems to want to tell me who made the call on putting money into the schools, where the problem isn't. The problem was on the streets. The problem was people going to their doctors, being overprescribed. Look at the settlements. That's where the money's coming from. And my concern is that ultimately the court's going to have a say in this. And I'm just wondering if the judge, who's a good judge, is paying attention, if he's going to wonder who's making these calls, who's making these decisions. Because there seems to be a splattering of this first round of money with the administration, evidently unnamed, but the administration making the calls. Now, I have a specific idea on how this became so quickly out there and put together, and we're just asking questions that aren't getting really answered, I don't think, properly. This young lady should have been able to tell me the individual who wanted to put money into the schools and why. And who has these programs. The reason they don't have these programs specifically for opioids in the grade schools is because the problem isn't there. They have DARE there. And don't ask me what I think of DARE. That's all I got.
Councilman Schron is next.
Thank you. You're going to hear a common thread. Some districts have programs.
Yes.
Define some. How many school districts do we have?
The list we received had 5, and I know there's a 6th.
Of how many school districts are there in the county?
31.
Okay. And so we're trying to address the other, 25 with this program?
No. So
who do we pick?
we haven't. We're working with the Adams Board and the Educational Service Center because the funding they receive from the state covers all 31 districts. And we figured the best way to get into all 31 districts and not just pick 4 or 5 was to work alongside them.
So the Adams Board is going to tell us again how they're going to spend the money.
Well, I think the lead on this one is the Educational Service Center, because the money, my understanding is, came from the Ohio Department of Education.
And you said you're having a hard time getting the information?
When we contact the schools directly, but when we go to the meetings with the Educational Service Center, we're getting more information.
And you're going to have some of this information sometime the end of the month or next month?
Yes.
And we're standing here getting ready to vote on funding. And you don't have the information for at least another 30 days.
Yes.
And you say, who identified the problem? And you said you don't know that.
No.
What other options were included so that we would know how we're supposed to be allocating these dollars when these options were selected?
Councilman, I'm not sure which options are you referring to?
The ones
Which
you're asking
component?
us to fund right now, which ones are excluded because every dollar is fungible?
I believe we're going to do a procurement to look at what programs exist, as well as what programs are in demand in the community, and then we're going to make decisions about recommendations on what to fund and what not to fund.
You're just talking about schools. As Mr. Gallagher pointed out, there's a myriad of other places to be spending dollars. We don't have any idea how these dollars were selected to go into this bucket.
Well, this bucket is just the prevention bucket for residents under the age of 18 that are served by the Family and Children First Council. Robin is just speaking to the specifics of her program. She's not speaking broadly to the other uses of funds.
Yeah, I'm just trying to get, how do we pick this number? How many people are trying to apply it for? What are we trying to take care of? And it sounds like we just kind of pick numbers out of the hat.
So Councilman Schron, again, Brandy Carney, Special Operations. It's my understanding that late last year, it was coming to a close on the opioid litigation. There was a need for the county to show immediately what these dollars would go towards for that settlement funding. And so there was a somewhat of a quick process to put together this initial $23 million. There was representation from both administration and council to show where that immediate $23 million would go towards and what projects would be funded. And so those are the projects that are in front of you today.
Please provide this body with the process. You said
Sure.
there was a process. I'd like to see the process. Show me what was considered, what was objected to, what was scored, which one got weighted, and show me what went on in order. When you say a process, that usually means you're considering all these things and you come down to these. So please provide me with the process.
Yes, sir.
Thank you.
Ms. Carney, how much additional money do we have besides the 23 million?
The entire fund is approximately a little over $116 million. Might be 119. I'm looking for Walter, if that's okay. Less the 23 million that we're talking about today.
Walter Perfowitz, Office of Budget Management. It's $116,730,695.55. Taking off this first increment of $19 million, $19,120,000 leaves us with about $96 million.
Okay. Councilman Jones is next.
Just to comment on what was said earlier, I remember when I first heard about the opiate crisis, I don't know, 6 or 7 years ago, the way it was illustrated to me was that sometimes high school kids were playing football. They get hurt and they start taking painkillers, and then the painkillers became a gateway into these opiates. And I'm not the expert. I really want to hear from you, but that's the way it was illustrated to me as initially things that were happening earlier. Are your preventative dollars simply going to start to prevent those type of things, raise awareness in that area? And if so, qualify for me the dollar amount in proportion to the overall, 23 million or so? Is that
It's
qualify
300.
what I just said for me?
Yes, to the councilman through the chair, it's $300,000, and yes, it's education to our young people around the dangers of prescription drugs and opioid use.
Okay. And the dollar amount that we're discussing is about $300,000?
Yes.
And what is the overall dollar amount again?
The dollar amount that's in front of you today, sir, is approximately $23 million, a little over $23 million in projects.
300,000 toward preventative education.
That's correct, sir.
Okay, thank you.
Ms. Carney, am I correct today's resolution is only to fund the first 19 million for the first year?
That's correct. These are 2-year projects, and some of the money of the 23 million would be spent between 2 years, so the 19 million is for this first year for 21
So
budget.
this resolution does the first 19 million?
That's correct.
Okay. Councilman Tuma.
Thank you, through the chair. It's my understanding from when the medical examiner came before this body a couple years back, he indicated, look, there's essentially two groups of people. There's people who are addicted and people who are not addicted. And in order to prevent people from becoming addicted, you have to get into young people, and you got to talk to youth, and you got to get a mindset out there that this is a bad thing where you don't even want to get involved in opioids or any type of drugs. And the way you do that is you educate. You just don't start at the high school level, at the college level. You get into the grade schools, you get into the middle schools. So I don't know that there's necessarily a problem in the schools. I don't have expertise on that, but I do know there's a problem outside of schools, and that if you want to resolve that problem as a community, then you better get inside the schools when they're young. And so the preventative medicine, if you will, is to spend these dollars in these schools and educate these kids, and that's part of a two-part problem. So I think it's worth having these monies go towards these educational programs.
Thank you, sir. As you said, awareness is key, and again, it was one of the 4 priorities, even in the opioid litigation settlement documents itself.
Ms. Baker.
Yes, thank you, Chair. The 390,000, is that going to be targeted to the, and you may have said this, I missed it, targeted to the school districts that do not have any educational opiate instruction advice? And what, or are we enhancing what's already there?
To the Councilwoman through the chair. So what we're trying to do, the reason we're trying to piggyback on the funding that's coming from the state is because we know it's a small amount of money, and it would limit the number of schools we can get into. So if we can piggyback on the plan with the Educational Service Center and the Adams Board, we would be able to get into all of the districts.
Do you have a concern that those districts that have instruction now are not doing an adequate job, that need our help to add more funding to what it is that they're already doing?
We'll identify that through the planning process. But as Councilman Gallagher said, the districts that have DARE, there's varying opinions on that, and they may want to try something different. We won't know that until we finish our discussion with the individual school districts.
Okay, I just don't want to see, because there's something already there, and because we have the dollars and we put it together quickly and we're trying to, appease a judge to show an educational piece, that we don't repeat what's already there. And I
think we will absolutely have to factor in districts that already have a program.
Okay, thank you.
Ms. Simon.
Thank you. I don't think this program is put together to appease a judge. I think it's to address the opiate crisis in the best way we can right now, correct?
Yes.
Thank you. Secondly, have you considered with the prevention model some of the MyCom programs too, when the kids are after school and we have them in a different setting other than school, perhaps that might be another place to put on some programming for those kids who are, I think, available as an audience.
To the Councilwoman through the chair, we did look at that option, but what we found is with prevention programs like this, the thing about after-school programs is hit or miss in terms of how many kids you get and whether or not the kids show up. Whereas in school, although you may have some absenteeism, for the most part, they're a captive audience, and it's the best way to get a large volume of kids if you want to get education programs out to them for prevention. Thank you. You're welcome.
Okay, anything else? Okay, thanks
Thank you.
very much.
So I would now like to invite Tammy Chapman-Wagner to come up from the Division of Children and Family Services. She can talk about both the use of funds for the START program as well as board and care expenses. And I'll let Tammy introduce herself.
Good afternoon, Tammy Chapman-Wagner, Deputy Director, Children and Family Services. So we received $3.5 million for the START program, sobriety, treatment, and recovery teams, primarily to hire our family advocates back. So the program is built off of a model in which social service workers partner with family advocates and they carry a caseload together. The family advocate works with the parent around substance abuse issues and treatment issues and helps them navigate the system while the social worker really works on the risk and safety issues and the legal issues with that family. In addition, we received or hope to receive $1 million for boarding care. We have about 3,000 children in custody right now and only about 300 foster homes. We partner with and provide contracts to about 40 network providers for foster care. But on any given day, our children are waiting for beds, and it is really difficult to find placement across the state. As a state, there are about 15,000 children in foster care at any given time and only about 7,500 homes. So it is a statewide, it's a national issue. We hope to release an RFP in June of this year for new contracting for boarding care to start January of 21.
Okay. Questions? Ms. Brown?
Yes. If there's such a need, is there any way we could expedite the RFP process to open that up sooner?
It's a very fair question. It is a huge need, and we unfortunately are still in a contract now. So we are under contract with a number of homes. We are actually looking at new models for board and care cost, and I think even taking the time we have now, we're going to use every day we have to look at our current contract, our current providers, and this board and care contract tends to be one of the most complicated contracts in the county, and I think we need every minute to manage it. Do you agree?
Absolutely.
I don't think we could get it out faster and have it be able to deliver a better system than what we currently have.
Okay, thanks very much.
Thank you. So, Council Chair, we still have Marty Murphy, who's here from Court of Common Pleas, and Hugh Shannon from the Medical Examiner's Office, if you'd like to call.
Yes, I would like to have them. And do we have someone from Metro?
We do not. I did not ask for all of the individuals to come today. I had asked for some of the larger projects or some that generated questions last time. But I can ask for Metro.
Let's move forward with the ones we have.
Got it. Court of Common Pleas, Marty Murphy.
Good afternoon, Council. Marty Murphy from the Court of Common Pleas Corrections Planning Board. The Corrections Planning Board has two different items in front of you. One is for additional task clinicians to conduct assessments. We anticipate that it is a total of 3 clinicians that would be hired utilizing these resources. We anticipate that the number of days it takes to get an assessment or a client seen in the jail, or even if they're on bail in the community, would be reduced by close to 40%. If you're looking at jail today, it is presently running about 14 or so days to get the referral, get into the jail, get the assessment completed, written up, reviewed by a supervisor, and then forwarded on to the judge, the bailiff, and the pre-sentence officer. Based upon the numbers we're looking at, the reduction, if it equates to an equal number of reduced jail bed days, saves the county close to $250,000 a year above and beyond the cost of the program. If you have any questions on that particular ask, I'd be happy to answer them.
Is this the clinical assessor's item?
Yes, it is, sir.
Okay, fine. Okay. Any questions on that? Okay, thank you.
The second item is to implement what we are calling Drug Court 4. The basis for this particular ask, and it was actually a part of our ask that was approved in the budget late last year, is based upon, if you look at the total number of people coming into probation annually, and this does not include the people that end up getting sent to prison or to some other alternative. If you look at that, just in probation alone, there are 6,000 new referrants annually. If you look at the number of probationers or pre-sentence and probationers, so it's a slightly larger pool, task gets roughly 2,600 of those to assess annually. So you're working your way down a funnel. If you look at those 2,600, right now approximately 1,300, pretty close to half, have an opioid diagnosis. Presently, the court in their current docket, in their current drug courts, to Councilwoman Baker's earlier question, we utilize federal grants to underwrite our veteran treatment court, which incorporates a lot of the elements of drug court. We utilize federal grant money to underwrite our opioid medication-assisted treatment drug court, and we utilize it to another federal grant to underwrite our recovery court, which is a co-occurring court that specifically targets females. Those females, in addition to having an opioid use disorder and being eligible for medication-assisted treatment, are additionally suffering from trauma. Oftentimes it is from sexual exploitation. And if you look at those courts combined, what we have today, our number of unduplicated new people that we're able to bring in annually is somewhere in the neighborhood of 165. The average length of time that they're in drug court is approximately 18 months. So you come in, you're one of the 165, you come in today, you'll be here until next August. When you look at 165 people out of over 1,200 opioid diagnoses being provided, it becomes clear that there is a much greater need for drug court than we're currently able to provide with federal funding or funding through the state of Ohio. We hope that this will impact that. And one of the reasons, and it's really key, we took a grant from the Ohio Supreme Court and paired that with a grant from the Ohio Bureau of Community Sanctions under the Ohio Department of Rehabilitation and Corrections about 30 months ago. One of the grants looked at specifically people going through drug court. The other grant looked at probation as usual. And what we measured were the number of positive urinalysis, and we drilled it down a lot more. We actually did it by drug as well. But the number of positive urinalysis, if you are engaged in drug court, came out to 3.7%. The N on that study for the drug courts was close to 7,000 urines. When we looked at probation as usual, or normal probation, people that didn't have the opportunity to get into one of the drug courts, and we looked at the exact same thing and the number of positive urines. We had a 28.7% positive rate. So it's clear that the drug courts actually make an incredible difference. The drug court model is validated as an evidence-based practice by the U.S. Department of Health and Human Services, Substance Abuse and Mental Health Services Administration. And it's a very compelling, these are very compelling reasons why we should be expanding out for a fourth drug court.
So can you explain what the plan is as to how the effectiveness of the fourth drug court is going to be measured going forward, what the metrics are going to be?
Let me take a step back in answering that, Mr. Councilman. The federally funded drug courts embed a 20% budget for research from an independent researcher. In our case, the primary investigator or evaluating party for those drug courts is Case Western Reserve University. For those drug courts, we are putting out of the federal awards approximately $80,000 per year into bringing together lots and lots and lots of data. That data across the other drug courts show that the model is effective and is working here. For this particular drug court, we're going to specifically measure the number of people enrolled. We anticipate that it'll be another 50 unduplicated annually. In their 18 months, they would be 82.5% or 82.5 engaged at any given time once it's fully operational. We will review the urinalysis results as I described earlier with the state Supreme Court and Bureau of Community Sanctions funding. We will look at the number of clients who are discharged successfully, unsuccessfully, or other. We'll look at where the unsuccessful discharge clients go to, for example, the community-based correctional facility or to a state prison. And then we will look at the number of clients successfully being discharged and the length of stay, that average of 18 months that the current drug courts do. A key difference with this drug court when you compare it to the federal drug courts that we currently run is they specifically target felony level offenders, and one of the criteria is they are high risk for drugs, but they have 3 or fewer felonies. In this drug court, we will blow past that threshold so that not only will they be high need on the substance side, they will be high risk for recidivating in the criminal justice system. So we will measure each and every one of those things and report back to that to Ms. Carney on a monthly and quarterly basis.
Questions by my colleagues? Councilman Gallagher.
Hi, Marty.
Hey, Councilman.
We gave you $1 million for the drug forecourt during budgetary.
I think it was for a 1-year period, a 12-month period. It was $632,000 in change.
Okay.
In this hour, we're asking for almost $1 million here. That's actually for an 18-month budget that goes through December 31st, 2021.
And what does that encompass? Because also there's clinicians in this that are separate, so it doesn't include more clinicians. What does it include?
It does include more clinicians. If you look at the drug court, they operate as a team, and they meet weekly. Team members include a representative from community treatment provider or providers, probation staff that have these specific clients assigned to them, and that is their caseload. It includes task clinicians that operate as case managers. So they are the clinical link in terms of where the client goes, if they are succeeding at that level of care, if they're going to be moved up in the level of care, down in the level of care, moved on to sober housing, engage with peer support, and so forth. So you've got the probation officer doing the criminal intervention, so to speak, the task person doing the clinical intervention. And also on that team and representing on a weekly basis include an assistant prosecutor, an assistant defender, the drug court coordinator, and the identified judge. So in this particular proposal, there are a total of 6 full-time equivalents within the court. It also includes a part-time equivalent at the prosecutor's office, a part-time equivalent at the defender's office, and a small amount of funding for drug treatment. Will be going to Scott for the rest of it out of that 10 million.
Right, so that's spread over the 4 courts then, right?
No, this will be spread over just this court.
Just that court?
Yes, sir.
What happens when the money runs out? Do we just deal with it then? Because if that's for 1 year, I mean, that's a bridge we can cross at another time, but I would put that in the back of your head as to how we deal with this going forward.
Are you, and I need a little clarification, are you asking regarding with
these are
opioid funds or?
Well, they're going to run out. I mean,
Sure.
They're finite. And I don't know if everybody gets that, but going forward, after it's all gone, what do we do? And that's always been something I worry about. Because I don't think the issue is going to go away
Sure.
just because the money goes away.
It won't.
So again, that's probably a bridge we have to cross when we get there. So
we absolutely will.
Okay, thanks.
Okay. Councilwoman Brown.
Thank you, Council Chairman. I just want to be clear. It was asked the question relative to the allocation of funds to drug court, and you said it was what?
For the 18-month period that this drug court will be operating, it comes out to around $950,000. The actual ask for 12 months that was presented and approved by the council in last year's general fund budget was $532,000 a year. The $900,000 and change is based upon looking at what will it take to run this court through December 2021, so for an 18-month window.
So is the task assessment specialist, which I understand to be the treatment alternatives to street crime, is that the same as drug court, or is that how? Because
Right. The treatment alternatives to street crime are the bridge between the criminal justice world and the treatment community. So they are there looking at the clinical side, moving the client up and down levels of care, looking at more intensive treatment, looking at subsequent placement once the client comes out of treatment and so forth. The probation officer is really doing the criminal justice piece. They will talk together in team if there is, for example, a positive urinalysis. Probation may have a very different perspective on how to deal with that versus a clinical person that would be following specifically the drug court model and the specific steps engaged in the drug court. So there are 2 clinicians. They will have, when fully operational, an average of 41 or 42 of the drug court clients that they will be seeing every single week on their caseloads.
Ms. Carney, did you want to add something?
I was just going to add, Councilwoman, that specific to this opioid funding, the $632,246 is being requested for 1 year of drug court, and the additional 300,000, which takes us to the approximately 900,000 that's been speaking out, is for the 2 years of the clinical assessors to support
For the entire drug court team for the 18 months.
Okay, thank you, Mr. Chair.
Okay, thank you very much.
Thank you, Council.
The question before the committee is on whether we would like to refer this resolution to the full council, presumably under second reading suspension to get programs going. I'd like to now open the floor for any questions or comments of any of the programs by my colleagues. Councilman Tron.
Ms. Carney, you said that there was a process that to get to us to this point where we're sitting here now having to make a decision. Was that process, did that start with $23 million and ultimately this year for $17 million? Or was the process you're going to present to us, you got that's written down someplace, derivative of identifying problems and then costing those out?
Councilman,
is the question clear?
Councilman Schramm, I know you asked about the process for the 23 million.
No, I asked about the process. Did the process start with a number and you then backed into these allocations? Or did you start with identifying what the problems were and then cost them out to get to 23 million? Do you understand the difference?
I understand the difference.
Okay.
I wasn't part of when I took on this job approximately a month ago. This was the initial allocation that was provided last year. These projects that are in front of you. So what that initial process was that you're speaking of, I wasn't part of that, and that's what I was planning to follow up on and ask for you. But these are the projects that were at that time that were identified for an immediate need, to show the immediate need to address this opioid epidemic.
Okay, but you're sure there's a process to get to this $23 million?
That there was a process? Yes,
Yeah.
sir. I don't.
And we started with a dollar number and allocated, or we build it up from a need?
I don't know, sir.
Okay.
We're going to call on Trevor McAleer to help us in this.
Good afternoon, Trevor McAleer, County Council staff. Councilman Schron, the process, and I know we touched upon this at the last committee, for the $23 million, that was the initial settlements prior to going to trial. Our outside legal counsel, Frank Gallucci, reached out to the administration and county council staff and requested that a plan be derived so he can show the court how the $2 million would be spent, or how the county would propose to spend those funds in order to show the judge and the court, so he can show this when he was headed into trial. At that point, we thought we'd be heading into trial. So what the process took place is that the administration, along with the direction of the council president, we had conversations with these entities. The administration had conversations with some of these folks, and we had conversations with others. And we came up with these numbers to give to Frank, that he then had the discussions with the court on this. There wasn't a judicial directive or anything that said this is how we have to spend the money, but there were no objections from the court regarding the plan.
Okay, so you're saying we started with the dollars, and then we let everybody put their best pitch as to how they're going to spend it, or we said you get 5 and you get 2 and you get 300,000?
We started with the 23 million as a whole, and we had the conversations with these different directors and department heads and others about how they would spend this money. So we didn't say, give us a proposal, you're going to get $1.5 million. We said, give us a proposal, and we went from there based off their request.
Mr. Chairman, just to add, because I was part of this process, everybody's looking for where the process was. It was explained just in the last meeting what the process was, but you are right. I mean, so it's absolutely true. We did start with the amount of money. That's the amount of money that was awarded. We were asked by our, it was the advice of our attorneys that we give an indication to the judge how we would spend this money, and so you are correct. We had the amount of money, and we did back into how we would spend the money. It wasn't an analysis of the need that came up magically with the same amount of money that we were awarded. And you know, a lot of this was the work of the council. A lot of it was the work with the council working with the administration. Some of it was the work of the administration itself. And we really didn't. You know, the proof I think was that from the time it was announced, we didn't get any serious pushback or criticism about what it was that we put forward. It was considered to be pretty sound stuff. Is it perfect? No. Do I have my own questions about some of it? Yes, but in terms of making decisions, you have to make them, and that's what we did. And so, yes, we did back into the number, and it was a reason we backed into the number.
Ms. Simon.
Thank you so much. I'm going to be supporting and make a motion when it's appropriate to move this out of committee for second reading, approval under suspension. But I have to say, we're in a crisis right now. We have an opiate crisis, and what we've been presented with is a solid plan to move forward with the first part of our settlement. And these are building on programs that are actually successful. When we look at the drug court, when we look at the Stella-Maris, and we all know we need beds, that's the critical piece, and we're getting that. Maybe the educational piece, it's a smaller percentage of the grand settlement, I think, is appropriate. Maybe we can tweak that a bit, but I think we need to move on this. I mean, Metro Health, all of these are sound institutions that have proven success in what they're doing. So it's a crisis. That doesn't mean we wait around and maybe get a better plan. I think we have a plan that's solid, and I think we better act as quickly as possible before more people die.
It would be an appropriate time, should I take what you said as a motion?
Yes.
Okay, we have a second, and Vice President Jones is next.
I just want to echo those comments and say that we're being watched as well. I've gotten calls from other communities who are receiving dollars, and they're actually looking to see what we do. So again, it is a sound plan. We have to start somewhere, and I certainly support. Okay, thank you.
Ms. Baker.
Just curious, for the director of the Adams Board, going back to my question on the 32 beds and knowing that people come in with multiple issues and you're going to divide that out and only charge the opiate part to the opiate treatment, are the other agencies that are going to be asked, do they have a budget in place for what that will cost them for the additional 312 clients that are anticipated to be served in 1 year, as you stated here? Have they submitted to you what they think they're going to have above and beyond what they normally pay for?
Yes, Councilwoman Baker, that's how we came up with the numbers that we were going to provide to them.
So the 5.4 million is your opiate money. How much more on top of that will be spent from other agencies that will be taking care of health, maybe mental illness, maybe abuse, who knows, all the different things that people walk in with? Do you know how much more you're going to be asking them to do because of the extra people that we're going to be taking care of?
Councilwoman, I don't understand the question, I'm sorry.
If someone comes in and they have 4 or 5 different issues, and your numbers person said, well, we're only going to pay for out of this opiate this much money, and that agency has their budget, now they're going to have to take that budget and raise it because they're going to be taking care of new people that we are now expanding the program to. Do you know how much more they are allocating in their budgets that they're going to have to account for that they may not have?
All of the services that they are going to be providing, that is part of the $5 million that Stella-Maris is receiving. That's why they're hiring the additional staff that is taking care of the money that we are providing them.
So that 5.4 million is more than just opiate treatment?
No, Stella-Maris does opiate treatment. That is what they are. They're an addiction agency.
And then if that person has, say, an abuse in their life, that you're going to have to refer them somewhere else, that's somewhere else, those dollars, are they budgeted for the extra people that you may be bringing them? Do they?
they already might be being served for their mental health issues somewhere else.
They may
So
or
they
may
might
not be.
already be in the system as well.
Okay. All right. Thank you.
To Trevor, could you comment on your analysis of the substitute?
Yes, so the proposed changes, Councilman Miller, I think the proposed changes or the proposed substitute makes sense. The only thing that I wasn't aware of, and I briefly talked to Brandy about this, is that I was not aware that the Thrive ED money will go through the Adams Board. But if that is the case, then the proposed substitute would be accurate.
Okay. Is there a motion? Yes. Oh, I know there's a first and second on the main motion. I was going to ask whether there's a motion to amend the motion and accept the substitute.
Moved.
Okay, so the motion is to amend by accepting the substitute. Is there any discussion on the substitute?
No.
All those in favor say aye.
Aye.
Any opposed say no. The ayes have it. The substitute is the version before the committee. Is there any further discussion before we move on sending it to the full council under second reading suspension? Councilman Schwan.
Ms. Carney, how much money is in the budget right now from the Adams Board for opiates right now?
In the Adams Board budget for just this opioid funding?
Not this. No.
Oh, Walter, do you happen to know? Felicia? I don't know that.
Okay. I think it's 10 million.
Well, it's $10 million for this
No.
opioid money.
I thought it was, okay.
Felicia Harrison, CFO for the Adams Board. Overall, the last annual report that we did showed that the opioid or SUD, substance use disorder, funding portion of our budget is around $18 million.
okay.
The rest of our budget goes for mental health services.
So this would be an additional $10 million.
Correct.
So right now, this is going to be total $27 million going through the Adams Board?
For substance use disorder, yes, for opiate and substance use disorder.
And all the statistics that we were just showing about success of this new 10 million, we could actually go back and look at the current 17 million that's going through and get some information as to how successful they are?
Yes.
Okay, thank you.
Am I correct that Ms. Harrison? Am I correct that the 17 million includes a lot more than opiates? It includes alcohol addiction and
Correct.
and all the other drugs that are
Yes, that's
a
correct.
factor. But opiates are a pretty big share of it at this time.
Yes.
Okay, my question was how much was opiates then of the 17 million?
I don't have that number exactly for you. I can get that for you and submit it to you.
Okay, thank you.
Councilman Miller?
Yes, Vice President Jones.
I have to say, you just opened a can of worms for me. You said it includes alcohol as well. Does it include substance abuse, like use of cocaine use as well?
Yes.
Yes.
It does. Oh.
Anything else? Okay, we have a motion and a second to refer to the full council under second reading suspension. All those in favor say aye. Aye.
Aye.
Any opposed say no. The ayes have it. The resolution is recommended as substituted. Thank you very much.
Thank you.
Mr. Chair, I'd like to
Yes.
add my name to this.
Okay, thank you. I'll add my name as well. Ann Tuma. Okay. There being no further business, we stand adjourned. Thanks very much, everybody.